Today's lecture will discuss the autonomic nervous system. Our goals for today, we will review the structure of the central nervous system and then the peripheral nervous system, and then we'll talk about the autonomic nervous system, specifically the sympathetic nervous system and the parasympathetic nervous system branches. We'll also review some of the common anticholinergic drugs that are used for general anesthesia and sedation, and then we'll also review some of the catecholamines and sympathomimetic drugs that are used for general anesthesia and sedation. Let's start off by reviewing the central nervous system and peripheral nervous system. As a basic review, we're talking about components that involve nerves. So here's your nice review of the neural anatomy with your dendrites, the nucleus, the cell body, obviously the nodes of Ranvier with the myelin sheath, and then the axon terminal at the other end, the distal end of the neuron. Remember that when neurons synapse with each other, what we're specifically interested in at that point is within the synapse, on the presynaptic component, you've got the vesicles with the neurotransmitter inside that. And the vesicles are released from the presynaptic terminal, and then those neurotransmitters travel across and then bind to receptors on the postsynaptic side. The different components of the central nervous system, obviously at the top you've got the brain, and then you've got your spinal cord, and all this is encompassed by a protective layer of the meninges, which is composed of three different layers. You've got the dura mater, which is the outer component. It's pretty tough and protective. The arachnoid matter and the pia mater is the innermost part. Within the peripheral nervous system, one of the ways to divide it is you've got the afferent division and the efferent division. The afferent division is all the innervations that are leading back to the central nervous system from the periphery. So most typically this involves the sensory components. The efferent division, you've got, this is innervations leading outward from the central nervous system to the periphery. And this typically involves the motor aspect, both the somatic and the autonomic. Here we see a nice review of the different components of the central nervous system. You've got the central nervous system on top and the peripheral nervous system, which is divided into or subdivided into the afferent and efferent divisions. And you can see that the afferent division is leading back upward to the central nervous system as the final terminal end. The efferent division obviously is subdivided into the autonomic and the somatic. And we're going to, with this lecture, we're going to particularly address the autonomic subdivision of the sympathetic and parasympathetic divisions. Remember, with the central nervous system, some of the different components that we're going to pay particular attention to is the hypothalamus, which you can see in the diagram on the right-hand side, is kind of deep within the brain. It's primarily tasked with handling stress and regulation, a lot of the autonomic or automatic components that keep the organism alive. So stress response, it's going to handle blood pressure control and temperature regulation. And then farther down within the brainstem, the medulla and the pons, you can see that these are the centers that house the respiratory control and the hemodynamic control as well. Now moving on, we'll look at the autonomic nervous system. As I mentioned before, the autonomic nervous system is really subdivided into two different categories. You've got the sympathetic nervous system, which is primarily, as you're well aware, is the fight or flight responses. And then you've got the other branch, which is the parasympathetic nervous system, and that's kind of your rest and digest responses. And so anytime we're discussing the autonomic nervous system, it's important to understand that what we have is kind of a constant balancing act between these two different branches, where depending on the situation, we may have an increase in sympathetic nervous system activity and a resulting decrease in parasympathetic, and then as that stressful situation resolves, we kind of get back to equilibrium, where we get a subsequent mellowing or decrease in the sympathetic and an increase in the parasympathetic. So we're kind of constantly finding that balancing point between these two different branches. This slide really looks at some of the research that's been done to measure the response, the stress response that we have with surgery. And so what we're looking at here is a graph that will illustrate the sympathetic response to surgery that we get. And so you can see with the black circles, that's measuring the norepinephrine levels, which is one of the main sympathetic neurotransmitters that's released, especially in response to stress. And you can see that with surgery, without sedation, that during the surgery we see a huge increase in sympathetic activity, and then you can even see an increase 3 hours after the fact. And so we see an increased sympathetic response to the stress of surgery, which makes sense. Whenever we incorporate sedation, though, you can see that we see a resulting decrease overall in the trend in terms of the stress response. So essentially with sedation we're able to lower the overall stress levels that the organism or the patient essentially is going to experience. So that's one of the benefits of incorporating sedation with your surgical plan. Now here's a really busy slide, and I don't want you to focus on the minute details. What I really want to get here is that you can see the two different branches. On the left hand side of the slide we see in blue the sympathetic nervous system and all the innervations that it has. And on the right hand side you can see the parasympathetic branch and all the innervations that it has. And really what I want you to understand is from this slide is that the majority of the organs in the middle have both sympathetic and parasympathetic innervations, and so we get this kind of constant, balancing act back and forth. Let's take for the heart, for example, and you can see that it receives sympathetic and parasympathetic innervations. And so we're able to, by altering the sympathetic tone or the parasympathetic tone, we can directly control or regulate some of the cardiac functions. Now here's a more simplistic diagram that kind of illustrates the difference or the different components of the sympathetic and the parasympathetic nervous system, and particularly what I want to drive home with this slide is that some of the structural differences that we see with the parasympathetic branch. Remember that we're going to have innervations coming down from the central nervous system, and then we're going to have a very long preganglionic fiber that's going to synapse out in the periphery at the ganglion. And those ganglion, you're well aware of all the parasympathetic ganglion. The otic ganglion, all the ones that we learned in anatomy, those are going to house those cell bodies. And so those ganglia that are out in the periphery are where we're going to get synapsing between the preganglionic fibers and the postganglionic fibers. On the sympathetic side, though, we have a very short preganglionic fiber and then a very long postganglionic fiber. And so those sympathetic ganglia are all going to align along the spinal cord. That's where all the sympathetic ganglia reside, and that really reflects the short preganglionic fiber and then the long postganglionic fiber. And you can see that coming out of that ganglia, the parasympathetic side, back to that side, the postganglionic fiber is very short, and then it innervates directly on the end organ. And then if you compare that to the sympathetic side, the postganglionic fiber is very long, and then it innervates directly on the end organ as well. There's some other differences that we'll talk about in terms of which neurotransmitters are responsible for or involved with the transmission for these various different branches. So let's start with the sympathetic preganglionic branches. Once again, the sympathetic preganglionic branch is very short. It's going to synapse within the spinal cord and then come out, and the cell bodies collect along the spinal cord, specifically from the thoracolumbar sections. Now moving on to the postganglionic sympathetic branches, the cell bodies are going to reside in those same sympathetic ganglia, and then they're going to, leading out of those, we have unmyelinated fibers that are essentially distributed throughout the body. And you can see that there is really an increase in terms of the ratio of preganglionic to postganglionic fibers. So there's, for every one preganglionic fiber, there's 20 or more postganglionic fibers. Now those postganglionic fibers tend to be much longer, because they have to run from basically the lateral of the spinal cord at the sympathetic ganglia all the way to the end organ that they actually innervate. And so they tend to be much longer. They're going to synapse directly at that point on the end organ, and the receptor that's involved at that point, they are adrenergic receptors. Now on the other hand, let's move to the parasympathetic branches here, starting with the preganglionic branches. This is known as the craniosacral division, and that's because this is where the cell bodies tend to reside, in the cranial aspect and the sacral aspect of the spinal cord. Now leading out of that particular synapse, we've got our postganglionic branches that are going to extend from the ganglion and that synapse all the way to the end organ. And so these are just like the sympathetic postganglionics. These are non-myelinated fibers, and they are going to synapse directly on the end organ. Unlike the sympathetic branch, the ratio of presynaptic fibers to postsynaptic fibers is 1:1. So for every presynaptic fiber that's parasympathetic, we've got a postganglionic parasympathetic fiber that matches it. These are also cholinergic receptors, but unlike they're not nicotinic, they're actually muscarinic. So it's a different subtype of acetylcholine receptor. And so with this diagram, even though the end organ is not one that we're typically working on, what I want you to focus on is the actual innervation pathway. And so if you start at the top, you can see that the sympathetic nervous system, the input comes down from the brainstem, and then it's going to synapse directly in the spinal cord, and you've got your short preganglionic sympathetic fiber. It's going to synapse within the sympathetic ganglion that's lateral to the spinal cord, and then coming out of that ganglia, you've got your postsynaptic fiber, which is going to be typically much longer. Now, if we compare that, and it's going to basically innervate at the distal end, right on the end organ. Now, down below, you can see the parasympathetic in red. You still got your input coming down from the spinal cord. It's going to synapse in the spinal cord just like the sympathetic branch does. However, we've got our long preganglionic fiber with our parasympathetic branch. It's going to synapse with the very short postganglionic fiber, and that synapse is going to occur in the parasympathetic ganglion, which are way out in the periphery. They're not next to the spinal cord. So some differences there. Now let's talk about some of the different receptor types that we have in both the sympathetic and the parasympathetic branches. So we're going to start by looking at some of the cholinergic receptors. Once again, we have the two different types. We have nicotinic and muscarinic. And the nicotinic receptors are found in the central nervous system, also in the, as I mentioned just on the slide previous to this, within the sympathetic nervous system and the parasympathetic nervous system. And these nicotinic receptors are also found at the neuromuscular junction. These are all nicotinic type cholinergic receptors. We also have the other type of cholinergic receptors, which are the muscarinic receptors. They're found within the central nervous system as well. There's several different subtypes of those. And they're also found at the postganglionic, within the parasympathetic nervous system, at the end of the postganglionic fiber, where it innervates directly on the end organ. With all of these cholinergic receptors, the neurotransmitter involved there is acetylcholine. And so it's got it's got a wide variety of functions. It functions within the central nervous system as a neuromodulator. Typically, it kind of slows things down a little bit. Within the parasympathetic nervous system, though, it's got a couple different functions as well. It functions at both within the autonomic functions as well as somatic functions as well. So when you tell your arm to move, the neurotransmitter involved at the end at that neuromuscular junction that actually is responsible for muscle movement, or at least one of the steps along the way, is acetylcholine. Acetylcholine is metabolized by acetylcholinesterase, and acetylcholinesterase is found within a couple different places within the cholinergic synapses, and then also right outside the neuromuscular junction. And so it sits right there, right next to where it's released at. And then basically once it's released, the acetylcholine is going to bind to the receptor, and then it's going to, once it diffuses away or moves away from the receptor, it's going to be chewed up and metabolized very quickly by the acetylcholinesterase enzyme. Here's another slide that kind of highlights the two different types of acetylcholine receptors. We've got the nicotinic on the left and the muscarinic on the right. If we look at the nicotinic receptor, these are ligand-gated ion channels. And so where they're found, once again, is within the central nervous system, both within the sympathetic and parasympathetic nervous systems, specifically at that synapse between the preganglionic and postganglionic fibers. And then it's also found in the skeletal muscle at the neuromuscular junction. The muscarinic receptors are G protein coupled receptors, so a slight difference there in structure. You can see the different locations. And then the big thing to remember, though, is the muscarinic receptors are also located not only within the central nervous system, but at the periphery, specifically where that postganglionic fiber innervates with the end organs. Here's a nice diagram where you can see a picture of the nicotinic receptor where it sits involving the neuromuscular junction. And so you can just kind of follow along with this diagram and see that, as that impulse comes down to tell the muscle to move, we get a change in the presynaptic terminal that triggers a release of acetylcholine. That acetylcholine is going to float across the synapse and bind to the acetylcholine receptors on the motor end plate, and then you see the change. And then basically we get a depolarization in the end plate, and that's going to trigger skeletal muscle contraction, and then the muscle is going to move. So looking at the muscarinic receptors, remember these are G protein coupled receptors. They're found on the heart, and the innervation there comes from the vagus nerve. And so the main activity that these muscarinic receptors have on the heart is it's going to function to slow the heart rate. They're also found in the lungs. The innervation comes once again from the vagus nerve, and they tend to cause bronchoconstriction and an increase in activity of the mucus glands in the airways, and so we're going to get an increase in the production of airway secretions. These muscarinic receptors are also located on the glands and in the GI and GU system. So within the glands, if you remember, cranial nerves 3, 7, 9, and 10, those are all the glands responsible for your spit, snot, and tears. So we see an increase in mucus production. And as far as GI and GU, that's going to involve your cranial nerve 10, your vagus nerve once again. We're going to see an increase in digestion, an increase in insulin and glucagon secretion. So that's part of your rest and digest functions. So hopefully at this point you can understand the wide variety of effects that acetylcholine has. It's a very versatile and well-used neurotransmitter throughout the body. And so if we alter acetylcholine function, this really can have a lot of different effects throughout the body. And the effects that we see really depend on which acetylcholine receptors are being altered. Inhibition, if we look at inhibiting acetylcholine transmitter functions, if we inhibit those within the central nervous system, that's going to have, basically it's going to alter some of the higher functioning systems. If we inhibit acetylcholine within the skeletal muscle, that's going to cause paralysis. And if we inhibit acetylcholine function within the autonomic nervous system, specifically within the nicotinic receptors, that's going to lead to alterations involving the autonomic nervous system, both at the sympathetic and the parasympathetic branches, so both branches. So we really don't want to alter the nicotinic aspects too much, because of the widespread functions or widespread effects that can result. So let's look at some of the anticholinergic drugs that are available. So as I mentioned, one of the things that we try not to do is alter the nicotinic effects very often. The one caveat there is skeletal muscle paralysis. That's commonly done in general anesthesia to prevent movement. But other than that, we try not to alter nicotinic function because of the widespread effects that can result. The muscarinic receptors, though, are a little different story, and we're able to alter those and have a pretty profound effect, essentially on the heart rate is one of the main things that we try to affect. So within the autonomic nervous system, if we're able to alter or give lower doses of acetylcholine, we tend to really stimulate and see more muscarinic effects. So things like a slowing down of the heart rate, an increase in mucus production, etc. It's not until we give much higher doses of acetylcholine that we tend to see more of those nicotinic effects. And so we're also able to really use receptor-specific drugs to produce the desired clinical effects. So if we give a drug that really only interacts at the muscarinic receptors and spares the nicotinic effects, we're able to kind of dial in and get exactly what we want. And it's really the use of these anti-muscarinics that we use it as on a more regular basis. And these would be drugs like atropine or glycopyrrolate, and we're able to specifically, selectively inhibit the muscarinic receptors and kind of block a lot of the actions of acetylcholine at those muscarinic type receptors. So these anti-muscarinic drugs effectively block the muscarinic receptors. These are acetylcholine antagonists. And really the clinical effects that we see depend on which muscarinic receptors that we're actually inhibiting, where those muscarinic receptors are located. So an example that we tend to see are things like if we administer glycopyrrolate, which is unable to cross the blood-brain barrier, we're going to see a decrease in the activity of the muscarinic receptors in the periphery, but really no alteration in the function within the central nervous system. Other drugs like atropine are able to cross the blood-brain barrier, and so we're able to see both central and peripheral effects. So some of the common anti-muscarinics that are available, you may see atropine or scopolamine, glycopyrrolate or ipratropium. These are all anti-muscarinic drugs. The two that we're going to specifically look at, though, are atropine and glycopyrrolate. So these anti-muscarinic drugs can be subdivided by their structure. The tertiary amines are atropine and scopolamine. As I mentioned before, these, because of their structure, they're able to cross the blood-brain barrier, and so as a result, you're going to see, depending on the dose, you can get some central nervous system effects. But effectively, from a peripheral standpoint, what we're doing, because we're blocking the muscarinic activity, is these are essentially vagolytic drugs. And so we're going to see an increase in the heart rate, we're going to see a decrease in secretions, and these are antispasmodics, a decrease in the GI motility. And that all really reflects the inhibitory nature of these drugs in terms of blocking acetylcholine's natural effect at those acetylcholine muscarinic subtype receptors. So with atropine, atropine comes a variety of different ways. It comes in a pre-filled syringe, which is what we see in the little box here. It's 1 milligram in a 10, so it's 1 milligram basically diluted in a 10 ml syringe, so each ml has 0.1 milligrams. It can also come in vials or ampules, and the concentration really varies, but this is one of the ACLS drugs that you need to have readily available. In terms of dosing of atropine, it really depends on what we're trying to accomplish. You can see for your ACLS protocols for asystole or bradycardia, the dosage really varies. But we can also use it as an anti-sialagogue, and that makes sense because if we're inhibiting the activity of the muscarinic receptors, we're going to block, or decrease the mucus production or mucus producing effects. And so you can see a smaller dose typically is enough to get that anti-sialagogue effect. Now, the other classification of the amines, we can have a quaternary amine. The typical one here is glycopyrrolate, and because of its structure, it's unable to cross a blood-brain barrier, and so we do not see any central nervous system effects with administration of glycopyrrolate. However, peripherally, it's still going to have similar effects as atropine in the sense that it's going to act as a vagolytic drug. So we're going to see an increase in heart rate and a decrease in secretion and some of the same antispasmodic effects. Now, with glycopyrrolate, one of the ways I like to kind of describe the difference between atropine and glycopyrrolate is if we administer at equipotent doses, atropine has a much quicker onset, and typically it's going to increase the heart rate much faster. So it's kind of like stepping on the gas and going from 0 to 60 in 2 or 3 seconds. With glycopyrrolate, that increase is it's usually not quite as large, and it tends to be a lot more gradual. So it's kind of like slowly accelerating from a stop, before getting up to speed, and it takes, a much longer time. So in terms of real time, with atropine, the effects are within 30 to 60 seconds. With glycopyrrolate, we really don't see the effects for 2 to 3 minutes, so it takes much longer. In terms of dosage, remember this is a parasympatholytic drug, so we typically tend to use it for its anti-sialagogue effects or to speed someone's heart rate up just a little bit by blocking the activity of the vagus nerve. The dose is about 0.1 to 0.2 milligrams IV. It's also used for whenever they're going to reverse the activity of the non-depolarizing neuromuscular blocking drugs like rocuronium or cisatracurium in the operating room. And they do this by combining it with neostigmine. And really what we're trying to do here is counteract the global increase in acetylcholine in order to prevent the increased peripheral cholinergic effects. So effectively, what am I talking about? What I mean at this point essentially is that we're trying to prevent the bradycardia that can happen by the increase in acetylcholine activity that occurs with the administration of neostigmine. Moving on, let's talk about some of the catecholamines and the sympathomimetic drugs that we may use. So let's start by looking at some of the sympathetic postganglionic receptors. Remember, these are receptors that reside on the end organ directly, and so these are all the adrenergic type receptors. So hopefully you're familiar with these. These are the alpha-1, alpha-2, beta-1, beta-2, and then also dopamine 1 and 2 are in there as well. we're going to primarily focus on alpha 1 and 2 and beta 1 and 2. So we'll start with the alpha 1 receptors. These are found on the postsynaptic side of the synapse, so on the effector cell themselves. So these are found in blood vessels, in the pancreas, in the intestines and bladder. But the main effect that I particularly want to make sure that you're aware of is obviously any increase in alpha 1 activity is going to cause, on blood vessels, is going to cause vasoconstriction, which is what we're going for when we administer our epinephrine with our local anesthetic. Alpha 2 is found not on the postsynaptic side, but it's actually located primarily on the presynaptic terminal. Beta 1 is primarily found in the heart, but also in fat cells, and once again it resides on the postsynaptic side, on the effector cell themselves, just like alpha 1. And the main activity you see with beta 1 receptors within the heart is it's going to increase the heart rate, it's going to increase contractility, and it's going to increase the conduction velocity. So the heart's going to beat faster, stronger, and we're going to see an increase in heart rate globally. Beta 2 is found in a variety of different tissues. Once again, it's found on the postsynaptic side, on the effector cell themselves, and they're found in blood vessels, in bronchioles, in the uterus, kidneys, liver, and pancreas. One of the things to be aware of is to remember, the activity within the lungs, within the bronchioles, is to cause bronchial dilation, so it's going to open those airways up. So the catecholamines, remember that these catecholamines are medications or neurotransmitters that directly stimulate these adrenergic receptors. We have endogenous catecholamines that are produced by the body, and they're produced from tyrosine and phenylalanine, and there's kind of a cascade as far as how they're produced. These catecholamines have varying clinical effects, and it really depends on what particular agent. They're agent specific. And each agent also has a different receptor selectivity profile that also varies not only on the different agent but also with different dosages. So here you can see the cascade in terms of the synthesis of these catecholamines. Starting with tyrosine, we move to dopamine, norepinephrine, and epinephrine. So the thing to remember really essentially is that epinephrine is a byproduct of norepinephrine. So here we see a variety of the different types of catecholamines. We've got our endogenous on the left and our exogenous on the right. And the thing to really remember is that they're all catecholamines because they have that same catechol structure that you see in the upper right corner. We see that the endogenous catecholamines include dopamine, epinephrine, and norepinephrine. And then our exogenous catecholamines include isoproterenol and dobutamine. So you may see these in your training or in your career at some point. And the exogenous catecholamines are catecholamines because they have that same catechol structure. So as I mentioned before, these catecholamines have different agent-specific clinical effects depending on the receptor selectivity, and that receptor selectivity also varies with different dosages. And so this is something I just like to review where that really highlights the difference in clinical effects that we see depending on the dosage. And so here we can see what they've done. This is research that was done where they basically did 1 mic per kilo bolus to dogs, and they measured the heart rate and the change in arterial blood pressure over time. And so they administered norepinephrine and then epinephrine and isoproterenol to these dogs and measured accordingly. And the thing to really take home here is that with norepinephrine, essentially what we see is more alpha 1 activity than beta 1 activity. And so what we see is an increase in blood pressure with norepinephrine, but an overall decrease in heart rate, and that's because we see that increase in blood pressure produces a reflex bradycardia, where the heart rate kind of slows down a little bit. Now with epinephrine, we see a little different profile. What we see initially is a high dose of epinephrine is going to preferentially turn on the alpha 1 activity, so we're going to see an increase in blood pressure. Okay, and so we're going to see a resulting reflex bradycardia, which is what we see. We see that systolic blood pressure shoot up a little bit, and then we see the resulting decrease in heart rate, just like we saw with norepinephrine. But as that epinephrine is metabolized and the levels in the blood start to decrease, then we see a shift away from the alpha 1, and we start to see more of an increase in beta 1 activity. And so actually what we see is as those levels of epinephrine decline, then we see the heart rate start to shoot up. And so that's why you can see from the initial decrease in heart rate, then we see the heart rate shoot up because we see more of a shift away from the alpha-1 to the beta-1 receptors. So those beta-1 receptors are essentially turned on at that point. With isoproterenol, essentially with that drug, really more of a control drug, what we see is more beta-1 than beta-2, so we're going to see really an increase in heart rate. We see some activity in beta-2, but really what we see with this research essentially is the heart rate shot up, and then we see really not much change in the systolic, but the diastolic really drop. And once again, that's kind of the reflex, kind of illustrates the difference in terms of vasodilation that occurs if we see an increase in heart rate. Now, in terms of what happens to catecholamines when they're metabolized, the majority of catecholamines are actually repackaged. So we see a reuptake of about 80% of the norepinephrine that's secreted, and then it's repackaged in the adrenergic neuron. That repackaging or movement, that reuptake movement away from the synaptic cleft can be inhibited along with by some other medications, specifically your tricyclic antidepressants, your selective norepinephrine reuptake inhibitors, or your serotonin norepinephrine reuptake inhibitors, are all going to decrease that reuptake action. Your MAOIs, your monoamine oxidase inhibitors, are going to basically inhibit the metabolic activity of your MAO, which is going to, it's one of the enzymes that's primarily tasked with the breakdown of catecholamines. So the monoamine oxidase that's present in the adrenergic neuron is inhibited when patients take MAOIs, and so we can see an increase in catecholamine activity. We also see catecholamine metabolism occurring in the extraneural tissue and then hepatically, and within the extraneural tissue, the two enzymes that are primarily responsible there are MAO and COMT, so monoamine oxidase and catechol-O methyltransferase. Those are both enzymes that help break down a lot of your exogenous catecholamines. And then the byproducts are essentially conjugated in the liver and then excreted renally. So let's move on and talk about some of the actual catecholamines that we use in medicine and dentistry. We'll start with epinephrine. It's I think this is the most common drug that we give on a daily basis if you broke down each local anesthetic as an individual drug, because several of the different local anesthetics contain epinephrine. So epinephrine, as far as its activity, it's a direct-acting agent. It's non-specific. It acts on alpha-1, alpha-2, beta-1, and beta-2. As I mentioned before, the activity associated with each of those receptors really depends on the dose. In terms of how this drug is metabolized, as I mentioned before, it's metabolized by COMT and MAO extraneurally, and then it's conjugated in the liver and excreted renally. It's commonly supplied a variety of different ways. You can see it in a glass ampule, which is what we see in the upper right-hand side. This is the glass ampule you'll see in your emergency drug kit. It's a very concentrated form of epinephrine. It's 1 to 1,000, which is 1 milligram per ml. It also comes in the pre-filled syringe, which is what we see down below, which is a less concentrated form. It's 1 to 10,000, so that's 0.1 milligrams per ml. So each ml is going to have 100 mics. Or it comes obviously in our dental cartridge, which is an even less concentrated form, a 1 to 100,000 or 1 to 200,000, which is either 0.01 milligrams per ml or 0.005 milligrams per ml, depending on which concentration we choose. Here's your ACLS, your different dosages for epinephrine. You can see your ACLS dosing up above. That's a very concentrated form. That's why we use that concentrated epinephrine, the 1 to 1,000. Essentially what we're doing with that really high dose of epinephrine is we're trying to get the activity of the alpha-1 receptors and cause vasoconstriction so that when we're doing CPR, we're able to effectively move the blood around. So that's kind of the dead man's dose. Some other reasons where we can give epinephrine, if we have an anaphylaxis reaction, certainly that's where we're going to administer epinephrine to once again help with the vasoconstriction to kind of counterbalance the vasodilatory activity of the histamine release. We don't give quite the big dose that we gave before. We're going to give a much smaller dose, either 0.1 to 0.5 milligrams IM or subcutaneously. And this is really where your EpiPen comes in. Remember that your EpiPen contains 0.3 milligrams, and that's given intramuscularly.
Epinephrine can be used to help treat severe asthmatic patients. Once again, we're going to give a smaller dose, 0.1 to 0.5 IM or sub-Q, and what we're really trying to do is give a smaller dose there to really get the beta-2 activity to cause those bronchioles to dilate. Some of the other sympathomimetics that we can use, these are synthetic drugs, and really they're designed to mimic the effects of the central nervous system, but they're not catecholamines because they don't have that catechol structure. So they're classified as sympathomimetic drugs because they mimic the effects of the sympathetic nervous system. They can act either directly or indirectly at the adrenergic receptors, and it really depends on which receptor is being stimulated as to what the clinical effects that we're going to see. So one example that I give here is albuterol, which is preferentially, it activates the beta-2 receptors in the lungs, and so we're going to get bronchodilation. Some of the other sympathomimetic drugs that we'll talk about ephedrine, phenylephrine, albuterol, terbutaline, amphetamines, and methamphetamines, just as a review as well. So ephedrine, we'll start with it. Its action is both indirect and direct, so it's going to be able to bind to that postsynaptic adrenergic receptors that are on the effector cell, but it's also going to stimulate the release of norepinephrine from that presynaptic terminal as well, so it has kind of a dual action. In terms of what receptors it stimulates, it's non-selective, so it's going to have alpha and beta, so alpha 1, alpha 2, beta 1, and beta 2 effects. The clinical effects that we tend to see at the dosages that we administer it, we're going to get a little bit of moderate vasoconstriction and a moderate increase in heart rate. We may get some mild bronchodilation and a little bit of central nervous system stimulation as well. You can see it's metabolized in the liver and excreted essentially unchanged. A large fraction of it, about 75% of it, is excreted unchanged. You can see it comes in a variety of different ways. One of the main ways it comes is a 50 milligram per ml vial that you need to then draw up and dilute. And so here we can see how it's applied. It's a 50 milligram per ml vial. It's a 1 ml vial typically. And so our goal really as far as dosing is we're typically going to give about 5 to 10 milligrams every 5 to 10 minutes. And we're going to give that for essentially a clinical picture where we have hypotension and mild bradycardia. We want to increase the blood pressure and increase the heart rate. Because it comes in a more concentrated form, we need to dilute it down. So what we're going to do is take a 10 cc syringe with 9 mLs of dilution fluid, so a normal saline typically, and we're going to dilute that vial into that fluid so that our final concentration is 5 milligrams per ml. Another sympathomimetic that we'll talk about is phenylephrine. It is a direct acting agent, so it's going to activate specifically or directly the alpha 1 and alpha 2 receptors. It's more alpha 1 selective, so we're going to get essentially vasoconstriction of those alpha 1 receptors on the smooth muscles, or on the smooth muscle of the blood vessels. And so the clinical effects that we tend to see are vasoconstriction. Now we can see a mild reflex bradycardia because of the increase in vasoconstriction, and that's kind of that balancing act that occurs. It's metabolized primarily by MAO and then in the liver as well, and then it's excreted essentially in the kidney. In terms of how it's supplied, typically it comes in a pretty concentrated 1% solution, which is 10 milligrams per ml. It's a 1 ml vial. And so typically we're going to dilute this twice. So we're going to dilute it in a 10 ml syringe, and then we're going to take 1 ml of that and dilute it again so that our final concentration is 0.01 milligrams per ml. The typical adult dosing, we're going to administer 0.1 milligrams every 5 to 10 minutes, maybe 0.2 depending on how hypotensive the patient is. Phenylephrine is also the active ingredient in nasal sprays, and it acts as a decongestant. And its activity is the same. It's going to cause vasoconstriction, and that's going to decrease the blood flow and the size of any edema and help resolve and kind of open up the nasal passages. The nasal spray is 0.5%, so that's 5 milligrams per ml. And so if we're going to use neosynephrine, it's typically used often in the OR prior to placement of a nasal endotracheal tube. We're going to administer 1 to 2 sprays each nostril, and it's given preoperatively. And remember that it needs a little bit of time to work. It doesn't work. It takes just a few minutes. Next, we'll talk about albuterol. Albuterol is a direct-acting agent. It's primarily, it's going to activate the beta-2 receptors in the lungs. And so the clinical effects that we tend to see are vasodilation. That's if we get any of the albuterol in the systemic vasculature. It's going to cause vasodilation. But, you know, most of the time we're administering albuterol via the inhaled route, and so that albuterol is going to bind to those free, raw beta-2 nerve endings in the bronchioles, and it's going to cause bronchodilation. And so that's really what we're trying to counteract, or some of the clinical effects that we see with asthma, the bronchoconstriction. Your albuterol is really going to help open those airways up. It's important to understand that the albuterol does not really deal with any of the other effects. Albuterol comes in a variety of different ways. It comes as an aerosol. It's a 90 mic per spray meter dose inhaler. It also comes as a nebulizer or a nebulized treatment that requires the use of a nebulizer, and it can come as an oral tablet as well. Typically, though, the oral tablet's not really that effective. In terms of adult dosing, with the aerosol, usually it's 1 to 2 puffs every 4 to 6 hours. The nebulizer treatment, it's one of those little nebulizers every 6 to 8 hours. I'll briefly mention terbutaline. Terbutaline is another direct-acting beta-2 agonist. The clinical effects are very similar to albuterol, and then we're going to see vasodilation and bronchodilation as well. Terbutaline is typically supplied via either a 1 milligram per ml vial or a tablet. The typical adult dosing in terms of the vial is we're going to give 0.25 milligrams subcutaneous every 20 minutes. And I think this is really a good adjunct to treating your asthmatic patients that maybe are having kind of recurrent or status asthmaticus. We'll wrap up the sympathomimetics by talking about amphetamines and methamphetamines. You know, these are some of the more common abused drugs that we see. These are indirect acting agents, so they function very similar to ephedrine. They have activity involving the alpha and beta receptors, and they also have, because of their structure, some central nervous system effects involving the alpha 2 receptors there. And this is really responsible for a lot of the clinical effects that we see with these patients on amphetamines, is that we see an increase in alertness, euphoria, and a lot of the sympathomimetic effects. And one of the main problems that we have with patients that abuse amphetamines and methamphetamines is that because they're constantly using or increasing the release of the norepinephrine that's stored in that presynaptic terminal, over time we can see depletion of your endogenous catecholamine stores, and so they're just effectively not able to respond to stress as well because they just simply don't have enough neurotransmitters available. So in summary, you know, one of the reasons that we like to talk about the autonomic nervous system is because we have a variety of pharmacologic methods available to really augment and alter the function of the autonomic nervous system. The autonomic nervous system is crucial because it really helps maintain hemostasis for the body. Thank you for listening. If you have any questions, please don't hesitate to contact me via email. Thank you.